Today we're covering a high-yield topic you'll see in class and in clinical practice: herniation of a lumbar disc. This is one of the most common causes of lower back pain, especially when it radiates into the leg. So let's walk through what it is, what it looks like, and how we assess and manage it. What is a herniated lumbar disc? Most herniations happen at the L5-S1 level. That's the lowest part of the lumbar spine before the sacrum. Think of the disc as the cushion between the bones in the spine. When that disc slips or herniates, it presses on the nearby nerves and causes pain. What kind of pain? Usually low back pain that comes with muscle spasms and something called sciatica, a sharp, burning, or shooting pain that travels down the buttock and into the leg. The sciatic nerve is a big nerve that runs down that path, so when it gets irritated by the herniated disc, you feel it. Clinical manifestations. Patients with a herniated disc often say their pain gets worse with things that increase intraspinal pressure, like coughing, sneezing, bending, or lifting. Bed rest usually brings relief, at least temporarily. There's also often a postural deformity. The patient may lean or twist awkwardly to avoid pain. One test we often use is the straight leg raise test. If you lift the leg while the patient is lying down and it triggers that familiar radiating pain, it's a positive sign. Other symptoms may include muscle weakness, decreased or absent reflexes, sensory changes like numbness or tingling. Assessment and diagnosis. Diagnosis starts with a good history and physical. You want to know exactly where the pain is, how bad it is, and what makes it worse or better. Imaging is important too. We usually use MRI, the gold standard for looking at soft tissue like discs and nerves. CT scan, sometimes used if MRI isn't available or tolerated. Myelogram, less common now, but helpful in some cases. Medical management. Our goals are simple. 1. Relieve the pain. 2. Slow disease progression. 3. Help the patient function better. Interestingly, bed rest is no longer encouraged. While it used to be standard, we now know it can actually make things worse by weakening muscles. Instead, we tell patients to avoid movements that cause pain, but to keep moving as tolerated. Here's what else we use: muscle relaxants for spasms, NSAIDs and steroids for inflammation, moist heat and massage to soothe muscles, physical therapy for stretching and strengthening, weight loss if needed, biofeedback for pain control and muscle awareness. If conservative treatment doesn't work, surgery may be needed. Common procedures include microdiscectomy, a minimally invasive surgery using a microscope, small incision, minimal blood loss, short hospital stay, percutaneous discectomy, another minimally invasive option. Laminotomy removes part of the bone to access the disc. Recovery is usually quick, but not always. Some patients may have relapse, meaning the disc herniates again at the same or a different level. And even with surgery, nerve damage can leave behind lingering pain or weakness. One complication we watch for is arachnoiditis, an inflammation of the spinal lining that causes burning pain. This can show up after surgery or after a myelogram. Let's talk about nursing care, both before and after surgery. Preoperative care. Patients are often nervous about spine surgery, so education and reassurance are key. You'll assess baseline pain, sensation, and movement. Ask about bowel bladder function. Teach log rolling, turning as one unit without twisting. Review deep breathing, coughing, and leg exercises to prevent complications. Post-operative care. After surgery, you'll be watching for bleeding at the wound site, neurologic changes, numbness, weakness, or loss of movement, urinary retention, could mean nerve damage, vital signs, and pain levels. If the patient had a spinal fusion, there may be a second incision where bone was harvested from the iliac crest or fibula. Positioning. Position is everything. Pillow under the head, slight elevation of the knees, avoid extreme knee flexion, turn as a unit, log roll. When getting up, roll to one side, push up with arms while swinging legs over the edge. Smooth and steady. Walking is encouraged the same day as surgery, but sitting is discouraged except for using the bathroom. Transitional and home care patients need a gradual return to activity. No lifting, driving, or twisting too soon. It takes up to 6 weeks for ligaments to heal. Heat can help with spasms, and structured exercises will strengthen the back. A brace or corset may be used in some cases. Patients may need rehab referrals, home care follow-up, pain management support, Assessment for changes in neurostatus.